lucky today to have Dr. Stevenson, Quyen, join us to bestow her wisdom upon us. That I have been lucky enough to have her presence for the entirety of my time at the VA. I looked up last night, Quyen, is that right that you've been at the VA for 15 years now? Does that?
Starting my 16th.
She is our centerpiece for our geriatric fellows and for those of us who continue to work at the VA longitudinally with any wound care questions that we have. That I give Quyen all credit for any knowledge that I have around how to help the patients that I see in clinic and in the nursing home at the VA with their wound care needs. She is one of those really special individuals who cares for the patients that I see, I think almost even more than myself. I kind of hesitate to send folks to her because they all love her so much. They tell me I'm not nearly as nice. But she owns the patients that she sees. She goes above and beyond for them, and she goes above and beyond for our learners, and really has a special way both with caring for patients and also with teaching learners. So thankful for her to talk with us about wound care today.
Good to go. All right. Well, thank you, Dr. Thomas, for giving me this opportunity. Oh, shoot, there's something wrong with this slide. Oh, can you see it? Okay. So obviously there's a lot of content here, and we're going to try next year to split it up in two. But one of the ways I make up for this is at the very end, you'll have all of my personal information, my personal cell, my work phone, my personal email. I encourage you just to follow up. But if I do my job right, there should be a good 10 minutes at the end for questions. So I'm going to just jump right in. We're going to go over common wounds and wound care questions, yeast infections and treatment, clinical pearls and wound evaluation, pressure ulcer staging, wound care medications and dressings, wheelchair cushions, bed mattresses, diagnostic imaging, differentiating between water-based edema and lymphedema because the treatment is absolutely so different. And then I'll just briefly go over compression stockings. And these following slides were requested after the last talk: diabetic foot care, corns and calluses, debridement, and then wounds for abscesses. And then lastly, the biggest thing requested was tips for ordering home health. So we pretty much break down wounds into two parts. They're either acute, most acute wounds, your skin tears, your lacerations, your first and second degree burns, they really should heal within 14 days. And then we double that for spinal cord injury patients. The chronic wounds are the ones that I'm seeing, and those are the wounds that fail to heal in 1 to 3 months, the pressure, arterial, venous, and diabetic. People ask all the time, if I have a diabetic ulcer, if I have a pressure ulcer, how quick should I heal? There's actually limited data on healing time, expected healing time, except for diabetic neuropathic ulcers. And the thought process and the science is if you have a diabetic foot ulcer that decreases in size 50% in 4 weeks, your chances of healing is pretty great without intervention. And the reason I use that as a benchmark is since diabetic wounds are so hard to heal, I use that as a benchmark for all of my wounds that I treat. And the biggest question always is, when should you refer to a wound care clinic? And I always tell people that really most of the wound healing, the first 3 phases, really happens in the first 7 to 10 days in most of our patients. It says up to 6 weeks, but really it's up to 10 days. And the reason that's important to know is everybody's got a different comfort level with wound care. So as arrogant as I am, I only give myself 2 to 4 weeks to see change, to either make a change, debride, or refer if necessary, or order further imaging. But you get to decide how many 2-4 week cycles you do before you refer. But just know, usually most of the healing is going to take place in that first 3 weeks. These are the same 5 questions. I've given this lecture for almost 15 years, and they're the same 5 questions, same 5 answers. Should you clean your wound with antiseptic or water? And this is where I like to interject that if I had given this talk 10 years ago, everything that I said today, you could Google and find and research. But this is actually my 25th year of doing dermatology and wound care. I just know it works. And what I can tell you is patients who shower without their bandages, just soap and water, they heal faster, they feel better, they're cleaner. And I have to tell you, after so many years, that you see a lot less infections with these wounds when they do that. Especially the elderly, you guys know they love to leave their wounds open to air. It's a simple thing, dry equals dead. And actually, believe it or not, the drier the wound, the more painful it is for the patient. And I do have one slide on when you actually want something dry, dead, and to leave alone, and that'll be the last slide. Topical antibiotic creams to use. Everyone is still prescribing Neosporin. And in 2010, Neosporin got an award for Allergen of the Year. Out of nowhere, we were seeing horrible skin reactions on neonates, so they stopped it in the ICUs. And then what we were really seeing is horrible, what we call latent allergies, geriatric patients who had been using Neosporin forever, and then all of a sudden they developed a rash. So now we don't use that bacitracin. I can tell you, I think it was 2011, I switched completely to bacitracin. I've never seen an allergy to it. And then that leads me to triple antibiotic ointment. Unfortunately, a third of that component is neomycin, so I stay away from the triple antibiotic ointment. And lastly, I always like to throw in a plug for Bactroban. It's so overprescribed, and it's the only thing we really have to treat a wound with MRSA. So I always like to say, just be careful with ordering Bactroban unless you know your patient's at high risk for MRSA, they have a history of MRSA. That's when I would prescribe that, but I would try to avoid that if possible. Most wounds you can actually treat with over-the-counter bacitracin. Lastly, how often do you need to change a bandage? This is a great question. All wounds, everything I show you guys later, all your dressings, all your creams, all your compression bandages, they can actually sit on the patient for 7 days. And your treatment changes purely based on how much they drain, how often they shower, who's doing the bandage changes. So just know, on the flip side of that, if you have a patient who doesn't come back for 7 days, it's actually okay. They're going to be okay. It's important to differentiate between candidiasis and tinea because the reality is candidiasis just responds so much better with nystatin, and tinea just responds better with the azoles. This I learned from a nursing student maybe 20 years ago. Why should you ask your patients to put on their socks before their underwear? Right now, in specifically spinal cord injury and patients over 65, the top two dermatology diagnoses right now is onychomycosis and tinea. So this is a very relevant, but if your patient has jock itch, always ask them if they put their socks or underwear on first. I'll tell you, if they put their socks on first, their tinea their jock itch will pretty much almost always resolve on its own because they're not dragging the tinea up from their feet. Antifungal topicals, the biggest thing I always get is, do you prescribe powder and cream? If you've got a big surface area or you have a patient who is high risk or constantly getting yeast infections, I actually prescribe both, and Medicare will actually pay for both. And that leads me into my next segment is everything that I talk about today, your dressings, your bandages, your topical prescriptions, your antifungals, all of this stuff is covered by Medicaid. I only talk about medications because most of the people I give these talks to aren't going to stay within the VA system. So just know every single thing on these slides is actually available through Medicaid, and I use them as a benchmark because if they pay for something, everyone else will pay for something. So I prescribe both cream and powder, and insurance will actually allow you to order both at the same time. And my instructions are very simple. For the powder, apply to quote unquote wet yeast, which they'll usually get in the summertime. And then I also give them cream for dry yeast, which they usually get in the wintertime. This is something we've actually done for almost 10 years, I think 2011, maybe same time. We started people who have significant area of tinea. I always like to mention that 1 30-gram tube of ointment or cream covers one adult body one time only. So just think, if you're going to prescribe a topical cream twice a day for even just 2 weeks, and it's 4 weeks for the feet, you're going to be using a lot of it. So one of the things we started doing is prescribing fluconazole, 100 to 150 milligrams. We started treating this like we did vaginal yeast infections 20, 30 years ago with just one dose only. What we were seeing is after one dose, 70% of patients resolved. After 2 doses, 20% resolved. And I rarely say 100%, but after 4 weeks, 100% success rate. And again, it's one of those things from empirical data. I don't think I've ever given 2 courses of an oral treatment to anyone more than, in my entire career, more than twice. So it's very effective. And so the SIG, I always like to say, I always give them 4 doses, and I say take one every 7 days, discontinue once the rash resolved. And again, 4 weeks, you pretty much will get almost complete resolution. This is my favorite slide. I don't have time, obviously, to go over the 4 most common types of wounds we'll see, but I love this slide. And the reason I love this slide is these are the 4 most common wounds you'll see, and they have distinct characteristics. And if you become so familiar with these characteristics of these wounds, you can really narrow your differential diagnosis. And they always teach us if you get a great subjective HPI, you should already have a couple of differential diagnoses ready before you even look at the wound. And this is where it'll help you. So arterial wounds, that first picture, are always at or below the ankle. They are perfectly round. Regardless of the size, they are perfectly round. It literally looks like somebody took a perfect punch biopsy. All of them are incredibly painful. And the biggest thing is there is rarely any healthy tissue. So again, unless somebody's been revascularized, most arterial wounds that we see in clinic initially will be usually 90 to 100% non-viable tissue. Diabetic neuropathic is probably the biggest thing. I always tell patients of all the stuff I do in my career, preventing an amputation is the most crucial. And I talk about that because that second picture, a callus, you will really rarely see in any wound other than a diabetic or neuropathic ulcer. So if you see a callus on a diabetic foot ulcer, that is the very first sign that their bone structures have permanently changed. It doesn't matter if the hemoglobin A1C is 5.6 or 11.3. You cannot change that process of that bone softening. And so, unfortunately, I get them when the callus is also already ulcerated, which takes months. However, on the flip side of this, if you guys see that callus, that's when their patients automatically qualify for 2 pairs of shoes and 3 pairs of custom inserts. And again, this is something that Medicare covers. It's just about documentation, which we'll go over later. And venous ulcerations, a true vein wound where you can treat with oral diuretics, you can elevate their leg, you can put them in simple compression stocks, you can tell them to watch their salt. They are 100% irregular. They're 100% superficial. And 3, you will only see 100% healthy pink tissue. So if you see a wound that even has hemosiderin staining, lymphedema, edema, if you guys see any depth, any sinus tracts, any slough, even if 10% of it's slough, chances are they've either progressed to lymphedema, or which is a completely different treatment, which we'll talk about, or they usually have an infectious process going on. Lastly, pressure ulcers, that's probably a bulk of our slides because that's what you'll see. Just know pressure ulcers over bony prominence should be perfectly round or perfectly oval. I always describe it like sticking my finger in a little bucket, and I should be able to feel all the walls of that pressure ulcer. If you guys see undermining irregular edges, always get therapy involved. It is always something that it's a movement problem. And once physical therapy sees them and they see that it's a transfer issue, maybe they're spending too much time on the toilet or the commode, either way, just get physical therapy involved if you have a true pressure ulcer with irregular edges or any undermining. Pressure injury staging, I cannot stress enough of all the talks about pressure ulcers. Just know you should really only be staging pressure ulcers. You know, we have our degrees for burns, we have our grades for diabetic ulcers. The reason that's important is when you stage a venous ulceration, which we get all the time, a stage 2 venous on the shin, unfortunately, you've actually given that patient a diagnosis. So Medicare has been doing it for years. They still want the note and staging done by a provider. They don't want it done by an RN. But the reality is that's just not going to ever happen. So my suggestion is it's just important for all of us, if possible, to stage. And if you don't know, that's when our differential diagnosis comes into play later. Pressure ulcers can occur from anywhere. The pictures I want you to focus on is that second picture with the oxygen tubing. And then that last picture is actually caused from a simple hospital sock. I love hospital socks too. All you have to do is I just make one little snip on the elastic band and you will never have this issue. I always like to remind people there's 4 spots in our body, our ear, occiput, bridge of our nose, and our malleolus, that there's absolutely no fat. So there is no room for error. These patients go straight from a stage 1 to a stage 4. There's no 2 and 3 with these types of wounds and on these types of locations. Stage 1 does not blanch. And the reason I included the bottom picture is I get consults all the time for a stage 1 pressure ulcer on a gluteal cleft. Unless a patient is cachectic or actively dying, the chances of developing a pressure ulcer in a gluteal cleft are really rare. So if you do see something in that area, I'll almost guarantee it's a yeast infection that you're dealing with. But again, does not blanch over a bony prominence. Stage 2 pressure ulcers were always superficial, always 100% pink. There cannot be any slough, depth, undermining sinus tracts. I think the year was 2009 when the National Pressure Ulcer Advisory Panel, who dictates how we stage wounds, included the bottom two: de-roofed, intact, serous or blood blisters, or automatic stage 2 pressure ulcers now, because the advisory panel knows that in order to get a blister, you had to have had underlying pressure with the shearing and friction. This is also the most important slide. An important slide is no reverse staging. I see it all the time. A lot of people don't realize humans do not regenerate that dermis. So once they've lost it, it does not grow back. And that's why your deep wounds, you will know that they will scar. They'll heal with a divoted scar. And so when you reverse stage, number one, you've given them a diagnosis that they don't have, a new one. And two, which we'll talk about with mattresses, is Medicare dictates what kind of mattress that patient gets based on that pressure ulcer. So the worst thing that happens to us right now is we put a patient on a great low air loss. They have stage 3 and 4. They healed, home health comes in, they see a stage 1 and 2, they downstage it, and unfortunately Medicare will absolutely come in to the facility or home and facility and downgrade their mattress. So that's why it's important to not, it's either a healing, recurrent, chronic, or healed ulcer. On the flip side of that, when you're doing your physical exams, look for those divoted scars over a bony prominence. Almost always, when you ask the patient, have you had a sore here or a bed sore, they will always say yes. Stage 3, I call my process of elimination stage. Obviously, no bone, muscle, or tendon. It's full thickness. And it can be not mostly some non-viable tissue, but mostly granular, because by the time you see them, they've been treated. So I call it my process of elimination stage. Stage 4 is bone, muscle, and tendon. That tendon and the bone are two patients I've seen recently. And my point of this slide also is these are how I'm getting these wounds. These wounds have not been present for 2 weeks. They've been present for 3, 6, 9 months. And that's why I kind of mentioned before, you get to decide when you feel comfortable sending a patient. But unfortunately, those 2 wounds were start of care visits. The same time, the advisory panel added blisters as stage 2. They now have added exposed hardware. And this is what we're seeing in our elderly. People who've had hip fractures, ankle surgeries, plates, pins. We're actually seeing pressure ulcers with exposed bone. And just so you know, when that happens, it is now considered a stage 4 pressure ulcer. And I mentioned this to Kyle earlier. It's a fast talk. You'll have all my contact information, and there should be 10 minutes for questions at the end. Unstageable, the biggest thing to know is 2 things. One, it is an ICD-9 code, but I tell people you have to be very careful when you diagnose a pressure ulcer as unstageable. Medicare considers an unstageable pressure ulcer a scab, so there is very minimal to zero reimbursement on these wounds. And we all know, looking at these 4 pictures, that these wounds are going to be needing debridement, offloading, expensive wound topicals for debridement, and probably frequent wound care. So my suggestion is always just stage the depth that you know. So in these, actually 3 of the pictures, minus the spine, I would stage those as a stage 3. And on a side note, I always write in parentheses, may evolve to a stage 4 once the wound base presents itself. And I can just tell you again from empirical data on those heel wounds in the occiput and the ankles too, when you take off that X scar, there will be bone exposed. 3 things is when you see, we're going to differentiate real quickly between deep tissue injury. These are those big purple butt cheeks that you see on your patients. And these 3 exercises will help you differentiate when to be concerned and when not. It's either going to be a true deep tissue injury, it's either going to be a Kennedy terminal ulcer, or it's going to be what Quyen, I think I came up with this on my own because I've never seen it anywhere, is the chronic purple butt. So you'll see that in a few minutes. So deep tissue injury, people ask me all the time, what's the ICD-10? There is none. It belongs with one of the stages. So if you have an intact dark tissue over a bony prominence, and you know for a fact that that patient did not fall or injure themselves, you would stage it as a stage 1 with deep tissue. If they have a blood blister, you would stage it as a stage 2 with deep tissue injury. So just know it's not an ICD-10. It belongs with one of the stages. You'll probably see this a lot, people who work in hospice and palliative care. It's called the Kennedy terminal ulcer. And the nurses, we call it a 330 syndrome. And the concept is the morning shift nurse comes in at 7 o'clock. She documents, does a full skin assessment, no skin problems. The swing shift nurse comes in at 3:30 and finds these wounds. And these are usually on patients who are very actively dying. And it's almost always the case that death is imminent, usually within 24 hours. And this is my patient, and I probably see at least 2 of these a week. And all I do before I freak out is I just push, and if it blanches, which it always does in your spinal cord, ALS patients, MS patients, patients who spend their entire days in a recliner, if you can blanch any of this, it's absolutely okay. And the way I document that is chronic purple expected discoloration on a patient who spends most of their time sitting. And if you can document easily blanches with pressure, we can rule it, the pressure ulcer out. And just know, as scary, every time I see this, as scary as it looks to the normal human, to me, it's actually quite beautiful as long as it blanches. Moisturizers, this is a big one. Most people can do well with hydrosarin, Lubriderm, anything over the counter, as long as it either says fragrance-free, white, or unscented is great. But we don't see that. We see the calluses, we see the elephantitis, we see the hyperkeratotic skin. And there's really only 2 prescription lotions that we know for a fact is proven to soften that tissue. And it's urea 20% or amlactin 12%. I'm just going to tell you, in the private sector, I stopped prescribing amlactin 12%. It became over the counter. So if I prescribe amlactin to a patient outside of the VA, I can't actually guarantee that insurance will cover it. And it is about $20 20 to $21 a tube out of pocket. And that's actually a lot of money for some people. So all I know is for 16 years now, working at the U and Evergreen and the VA, urea 20% continues to be covered by all insurance companies. So that's what I stick to. I usually don't prescribe 40%. I leave that to the podiatrist. And then urea 10%. We see a lot of patients who've had chemotherapy, who have those thick, dry hands. And that's where the 10% is great when you're putting it on a hand or fingers. Wound care topicals, again, all of these are paid for by Medicare and Medicaid. I just gave this exact same talk to 20 PMNR fellows in Vanderbilt in Tennessee last week. And I gave these same slides. I just did the same thing for gerontologists and primary care doctors at Emory a couple months ago, and I gave the same slides. So just know, wherever you practice, you can use these and prescribe them. Silvadene, my absolute favorite drug on the entire planet. You can pay the same $5 copay and get a 400-gram jar. It's like getting a topical antibiotic without side effects. It is so underutilized, but such a great treatment for all you guys' trauma wounds, all of your infected wounds, and of course your burns. And don't learn the hard way like I did early in my career. If somebody has an oral sulfa allergy, they will absolutely react to the topical. Santyl collagenase, just briefly, the reality is you guys probably won't be prescribing these, but it's always just good to know. Santyl collagenase is the only debridement ointment on the entire planet. It's $200 a tube. And the reason it's so expensive is it only eats dead tissue. So if you have somebody who can't see, they accidentally put some outside of the wound bed, just know it actually will not damage the outside tissue. Iodosorb is also one of my favorite creams. It's literally just iodine in a gel. Unfortunately, it's also about $180 to sometimes $300 a tube, but there's nothing like it. I call it my amputation prevention ointment. All of my diabetics patients, even if they came to me when I was a primary care provider, got one of these 2 prescriptions. If you order either one of these for your diabetic patients and they get a sore and you tell them to put it on daily until they see you, almost always, if it's an acute wound, they'll be healed before they show up in your clinic. The biggest thing with iodosorb, same thing with the sulfa. If somebody's allergic to shellfish iodine or betadine, they unfortunately will react to the iodosorb. It's a great debridement. triple antibacterial properties, and it's very absorptive. So this is a great option if you have a patient who can't change their dressing frequently. You can actually leave this one on for 3, 4, 5 days. And that's how I differentiate whether to do the Santyl or Iobazorb. For almost 20 years now, I have only prescribed triamcinolone 0.1%. Middle of the road, doesn't harm anyone. I always mix it with some zinc so you don't have to worry if you have to put it on somebody's arm. Just know 2 things with this. After 21 consecutive days of use, it will permanently thin the skin out. So I only prescribe it for 14 days. The other thing to know is I always prescribe it as a BID dosing just to justify the quantity I'm prescribing. But just so you know, pharmacists have confirmed this, that there's no clinical benefit to adding a second dose. I call it a mental health dosing. Some people just feel good at night. They put some extra triamcinolone. But on the flip side of that, just know if your patient can only do it once a day, they're still going to get the same benefit. Zinc oxide 20%, I call adult butt paste. They literally took Desitin and just added pain reliever. The calmaceptine has menthol in it. The zinc oxide is just a 20% with petrolatum. I like zinc oxide 20% because you can actually order it in a 400-gram jar. And again, all of this stuff is covered by insurance. If you order calmaceptine, it's risky whether insurance will pay for it. But if you order zinc oxide 20% alone, it'll always get paid for by insurance. Just real quickly, does vehicles matter? Ointments are just, we know, are much more potent than creams. And this same slide still exists. If you Google it or if you look this up and up to date, it's the same slide, even though this was printed in 1997. It hasn't changed. Just a cheat sheet for you guys when you order ointments and creams that certain vehicles work better on different parts of your body. I'm not going to go too much into wound care dressings, but the reason I start with these 2 is this is available pretty much in every single pharmacy over the counter. It's available in all of your clinics. It should be available in all your ERs. It's such a simple dressing. That Vaseline petrolatum, I have yet to see an allergy, even on babies. We put on children. I've never seen an allergy to it. So your skin tears, your superficial abrasions, your burns, it's great. It's just a great product to have because very few people are allergic to it. They heal great with it. And it's incredibly cheap. I think it's like 33 or maybe 20 cents a piece. People don't realize that the yellow gauze, they call it, is all it is Vaseline impregnated with betadine. The one I prescribe it is when somebody has like coming in with venous stasis with cellulitis. If you have a patient who's on antibiotics, immune system's a little shot, that's when I choose the zero form over the betadine. And again, you should be seeing all of these dressings. And again, they're also covered by Medicare and Medicaid. Wound care dressings, just know now we have silver-based products. They've been out for 20-something years. Up to date, VA is very evidence-based research, so it took us almost 10 years to get this approved and brought into the VA healthcare system, into the UW system, because there still is no data proven that silver really improves wound healing. But this is where empirical data comes in. Sometimes I have a wound that just has enough bioburden. They don't need antibiotics. They just need to minimize that bioburden. And that's where you add a silver product. And just from experience, you add a silver product to a chronic wound, they usually heal very quickly. And then I love to ask this question. If anyone's been with me in clinic, I ask lots of questions throughout the clinic. And the biggest one I always ask, and very few people get it right, is the difference between an antibacterial and antimicrobial. What's the difference? Your antibacterial is your betadine, iodine, and of course, antimicrobials are silver. The reason it's important to differentiate is antibacterials cannot do anything to the bacteria that's currently on the surface of the wound. It could just prevent new from forming. That's why I always prefer the antimicrobial. It kills what's there, and it also prevents new bacteria from forming. I'm just going to quickly go over this. The reality is none of us will be ordering this stuff. You're always going to have a specialty do it. Just know it's out there. And this is when we're going to get into home health orders. Don't use any brand names. Just stick with the generics. But really quickly, calcium alginate's been out forever. It just is dried algae. It holds 10 times its body weight. You can put a Vaseline gauze over a venous ulceration. You can use it as a primary or second dressing. If somebody can't change their dressing frequently, we'll add an alginate over the venous. So a lot of these dressings can be primary, secondary layers. Biggest thing with foams, they hold 10 times their body weight as well. Just know anything bordered can't be cut and anything non-bordered can. I saw an unfortunate case with an MS patient this week who unfortunately took a huge, he's incontinent of urine and feces, and they cut a large sacral Mepilex in half, and the entire thing was saturated with urine and feces. So just know the borders can't be cut, but the non-bordered can. Honey's been out for a long time. I'm not a fan of it. It burns. Everyone knows Quyen doesn't like it. But on the flip side of it, I will tell you, just because Quyen doesn't use it, people use it all the time. It works for a lot of people. It's now been FDA approved that they can advertise that they're now also an antimicrobial and a debridement cream. Hydrocolloids, I think this is the oldest dressing on planet Earth. It's really great for superficial stage 1 and 2 pressure ulcers. And the great thing about this is you can actually, they're waterproof. It's the same material that's made of an ostomy wafer. So these are great because you can leave them on for a week and they can shower or not. Collagen, it's the greatest invention to mankind. It is the only wound care dressing, again, covered by everybody, used by everybody. It's the only dressing that A, melts into a wound bed, and 2, can physically grow. The original name was Pomegranate. It can actually grow new tissue. I'm not sure your patient population, but I get a lot of patients who get INDs, or INDs or IV drug use, and I can almost tell you 75% of them, when I see them, they're not going to come back for that follow-up visit. That's just the truth. And if they do, they're also going to be the ones who are going to utilize the ER for the Saturday, Sunday visits, which we don't want to happen. So point being with that is when you have a patient, you're not sure they're going to come back. I just debride the living daylights out of that thing, and I stuff as much collagen as I can and then just cover it with whatever covered bandage. The best part of that is if you have a patient who you can't guarantee will come back and you put collagen in there, if they prematurely close, no problem at all. They've healed with something that dissolves into the tissues. Wheelchair cushions, the biggest thing is for your stage 3, 4s, it's always best to just get OT-PT eval. I'm not sure why at the VA, but they will only issue a wheelchair cushion if the patient got the wheelchair at the VA. I've never quite understood that. But one of the things we started doing that you guys can actually do without a physical therapist is get a low profile one. The low profile Rojo cushions, those EHOB waffle cushions. You guys can actually order this from your local DME without having a PT. They all 3 will treat and prevent pressure ulcers up to and including stage 4 pressure ulcers. So just know if you are kind of stuck, and the best thing also about the low profile for all of us is they can carry it around. They can put it on their dining chair. They can put it in when they drive. They can actually carry it around. And because it's low profile, they won't fall if they don't have a wheelchair setting. Lastly, most insurances will allow you to replace it every 3 years. And donuts, I can't stress enough, I truly believe that they were just meant for pregnant people because people will be given a donut for a sacral wound, but then they come to me with 2 ischial wounds. So just know if you're trying to use it to prevent the sacral wounds, great job. It'll heal that, but then they're going to come back to you with 2 ischial wounds. So just be careful with the donuts. Just know your mattresses. There's just 3 types. The thing the providers just really have to focus on is the group 1 and group 2. The group 1 is all those thin overlay, your gel, your foams, you can just put right over a mattress. That's why it's called an overlay. Anyone qualifies for it. Again, Medicare and Medicaid will pay for it. They can have as many stage 1s, but they can only have 1 stage 2 to qualify. Anything more than a stage 2, they automatically get a low air loss mattress. And I'm just going to kind of throw a plug in there after working as a home health nurse for 9 years, especially for Medicaid and Medicare. They rent these mattresses to your patients for until the wound heals. Or this is where I'm going to throw in a plug, is if you can somehow let that patient keep that mattress after 12 months, they own it. So I'm not encouraging you to lie or try to keep a pressure ulcer open just so they can keep it, but just know after 12 months, the patient will actually own the mattress. The biggest thing to know is 3 layers, not to exceed 3 layers of anything between this wound and the mattress to get the maximum benefit. And then the biggest thing I cannot stress enough is there is no mattress out there that can actually offload the heels. This is where we get ourselves into trouble, as we think we put an air mattress on, and then unfortunately they develop heel ulcers because they weren't offloaded. Diagnostic imaging, the reality is if I had my way, I would say, unless that patient doesn't have diabetes, doesn't smoke, has some hair on their foot or toes, you can palpate a pulse, you want to start compression right away. For all the other ones you see, you've got to be able to differentiate between ordering an ABI or a TBI. The difference is normally if somebody doesn't smoke or have diabetes, we can do an ABI. We take blood pressure on the top, arms, blood pressure on the ankles. Ankles are higher pressure, smaller vessels. We divide the two and should get a number greater than 1. But for whatever reason, diabetics, you're going to see these crazy elevated numbers greater than 1. And when you see a number greater than 1 on a diabetic, it's very falsely elevated because the vessels are so calcified. However, for whatever reason in humans, the hallux vessels rarely calcify. So on all your diabetics, it's really just safe to order the TBI, all the labs order it. And if you don't know, order both, they'll do both. But TBI is the biggest thing to know is because the toe pressure and ankle pressure are 20 to 40 point different. A normal TBI is 0.7. And the reason that is so crucial to know is if I'm reading a 0.7 reading on an ABI result, I'm going to be incredibly cautious about the kind of compression I put the patient on. So just know that difference. You got to differentiate between the edema or lymphedema. I see it so many times, patients in the ICU, kidney failure, they're on 120 milligrams of Lasix trying to get rid of that lymph fluid, and it doesn't work on lymphedema. So you got to be able to differentiate the two and know when to alter your treatment. So your water-based edema we talked about, I'm just going to tell you, reality is most of them will pit. So if you have a patient with a leg that has pitting edema, that is the water. You can put them on diuretics, watch their salt, get any ready-to-wear compression stockings, elevate their legs, and they should do great. Unfortunately, when somebody's had lymphedema, either trauma, surgery, cancer, but mostly in our case, obesity, and they haven't been wearing compression stockings, unfortunately, once they've leaked the fat, the cobblestone, the elephantitis, they call them the sausage toes. Once they've leaked fat, the only cure for that is actually lymphedema therapy. You guys are all entering healthcare at a great time. When I started, there were very few lymphedema clinics out there, but now they're all over. You can get them any clinic, any hospital. And again, I gave the same lecture to Emory in Georgia, and last week I did it to Vanderbilt, and we can still say the same thing. So once they've leaked lymphedema fluid, nothing can help them except for the lymphatic massage. 2 things to be said about that. People think it's going to hurt, but I'm just going to tell you, I think I can count on less than one hand how many patients truly ever hurt from it. It feels good. They're getting a massage. And on the flip side of that, it is so effective because after they do the therapy, the therapist will put them in custom compression stockings. They'll get them in the lymphedema pumps. And I'm almost certain I can tell you in 15 years at the VA that maybe only 2 people have I ever had to send back for a second series of treatment. It's that effective. So once you identify lymphedema, put it in your chart. And in the private sector, even if you don't know if it's lymphedema, you know what I always say, Medicare and Medicaid will pay for it. If you even just write it out, rule out lymphedema, there's differential diagnosis, edema versus lymphedema, they'll still pay for it as long as they see that one word in your chart. Compression therapy, just know there's 2 types. Anything that you get from a counter, you can just measure their calf and ankle. You can order, just know everything VA included in a private sector, they qualify for 6 pairs a year. Once they get into the gradient custom stockings after they've had the lymphedema treatments, they'd get 2 a year. And the reason why is they're about $550, $600 a pair. I'm not going to go too much in compression therapy. We'll try to do a separate section on that. But the biggest thing to focus on this slide is that top picture. I can't stress enough, even if they just have one wound on the ankle or one wound on the calf or one wound on the foot or heel, they should always have a compression bandage that goes from that 5th met head, not covering the toes, to 1 inch below the knee. And sometimes I like to use the scenario of I don't think any of us have ever really seen a compression stocking that's missing the leg or one that's missing the foot. So just know if you truly are treating edema, it has to be from that 5th med head to 1 inch below the knee. Just really quickly, Una Boot's been out for a long time. Dr. Una was a dermatologist in Germany. He used this. It's calamine impregnated Curlex. He used it just to treat stasis dermatitis. And what he discovered, and we all know, is it's very rare to get stasis dermatitis without underlying edema. So if you're ever going to use Univot, you really should be using an ACE or a Coban over the counter to secure it. I will tell you that it is only effective and mostly effective for patients who are ambulatory because it turns into a calf or it turns into a hard cast. It really only is effective when they're walking. So that leads me to the last two. We now have two-layer Coban compression bandages, and this is great. These are for the 30 to 40 compression. They can still get their foot in a shoe. It absorbs a crazy amount of moisture. You can leave it on for a week. And the best part is these were meant for people who are sedentary. We can actually get the same benefit in patients who never walk, or ALS or MS, and our spinal cord patients. This is still beneficial because of the type of compression that's being used. Diabetic foot exams. This is what you guys will see a lot. A couple of things. One is I always see it all the time in the notes. Sensation intact, not intact. What people don't realize is you actually have to test 10 points on somebody's foot and score it to actually physically diagnose them with loss of protective sensation or peripheral neuropathy, and you can do it on the spot. So these are the 10 most common spots that if you're diabetic or neuropathic, you're going to get a callus, and then you're going to get a sore. If they can feel 7 or more spots on each foot, they pass. 6 or less, they fail. And so just so you know, that's probably the best way you can really diagnose neuropathy on the spot. 3 things for seniors. Don't, I don't think people realize almost every single senior center now has a foot clinic, and it's usually out of pocket, unfortunately, $15 to $40 a piece. It's run by mostly retired podiatrists or foot care nurses. But if you have no other option for your patient, don't hesitate to send them to a senior care. They don't need to be a member to go. Moisturizing lotions, I just always write on my SIG, avoid between toes. There's no fat between your toes. So if they get caked lotion, they'll get 2 sores with bone exposed. All my diabetics and really anyone with any lower extremity wound, I only order white socks. They do not like me for that, but the reality is that's what saves us. That's when they realize a bandage has drained through, or they realize they've cut themselves and they're bleeding. And that's actually how we find a lot of wounds, is patients come in with a bloody socks. You are going to get patients, that leads me to the next slide, who when you say diabetic shoe, they're going to think they're going to get a very, very ugly, large leather shoe with one big strap, that top left one. But if you have a patient who really does not want that diabetic shoe, just get them to get whatever shoe they want, but get one with a removable insert, so at least they can get a custom insert to put into that shoe. And the whole thing with this is you always get 2 pairs of shoes or inserts a year. And I'm telling you, even on your patients who don't have diabetes, if you guys do that 10-gram monofilament test, even just once a year, and you have it documented, they will qualify for these shoes. And they get 2 pairs of shoes, 3 pairs of custom inserts every 12 months. Corns and calluses, I always get asked, how do you know which one is which? The corns are very painful. It is very rare on somebody, even with great sensation, that they're ever going to hurt because of a callus. So just know, we don't know why corns form. I can just tell you from empirical data, I mostly see them in men. I can also tell you I mostly see them in people who wear socks at night and sleep in them. All I have to do is ask a patient, do you sleep in your socks? They say yes. And I say, well, that's where you got it from. And then the third thing I can tell you is if you can get that core, that entire root out, 100% of the time, it will never come back. But this is where it gets tricky, is in order to do that, we have to make people bleed, which we don't want to do. So just know, if you are able to get it out successfully, it won't come back. Quick thing on the slide. I can't stress enough, this is the same patient, same heel, same time, same wound. If you didn't pick up the foot, you're going to miss this ulcer. So when I see it mostly in inpatient, people will just lift up the sheet, look at the foot, put it back on. But just know, just lift up your heels or you're going to miss something as severe as this one. People ask me all the time, when do you debride? When do you not debride? If I can put into one sentence in my assessment, dry, stable, and intact, all 3 words in one sentence, I don't touch it. Gone are the days where we just try to remove these eschars or scabs intact. But honestly, at this point, we just leave them alone. If you have somebody with an intact blood blister, an intact water blister, what we do with those is we paint them daily with iodine, over the course of 1, 2, 3 weeks, it hardens the outside, and eventually, most of the time, the fluid reabsorbs beautifully back into the tissues, and then you don't have a problem with the wound. If you have a high friction area, you're worried the patient's going to pop it, then that's when we just kind of cover it with a gauze or acrylics. But really, just paint these things with iodine once a day, allow it to air dry. Most of the time, it'll reabsorb beautifully, and you will not have to deal with a wound in the future. But of course, debris fluctuant eschar, and the biggest thing with this is that bottom one, even if 90-95% of that eschar is beautiful, dry, stable, intact, but you've got 5-10% of it that's loose, it just all has to come off. The infection risk is really high. This is a new slide that I've been asked to do. Just know, and the research is still out there, I always, from time to time, when I give these talks, I try to just look at the research again to see if it's changed, but it's always the same. Abscesses that are usually about 5 centimeters, I don't pack anymore if they're 2 inches. The biggest thing to know is gauze is the absolutely most painful dressing. And if you do order gauze, unfortunately, that's a daily to 3 times a day dressing. This is when you want to get your patients into wound care, because there are just so many different packing material that we can actually put on that's meant to be stayed on for 2, 3, 4 days. And so the patient doesn't need to utilize the ER. You don't have to train anyone in the home to change the bandages. Lastly, I've never really believed in a wet to dry. It never made any sense to put a wet gauze into a wet wound to pick up anything. And if you put a packing into a sinus tract to wick fluid, it's not even possible for it to wick fluid if it goes in wet. So my thing is I put everything in dry because it's already going to be wet. If you do that, it's going to absorb more, and it's actually going to probably do what it's supposed to do, which was originally it sticks to non-viable tissue and it pulls that dead tissue out. Tips for ordering home health care. This is from 2 sides. One, from me being a home health wound care nurse for 9 years and me being an NP for 15 years ordering it. Here's the truth. If you ever order more than 2 times a week, it's going to be incredibly difficult for you to find a home health agency that will take you. But sometimes they will, but try to minimize the frequency to 2 times a week. Sometimes they'll do 3, but the best is try to get that family member or caregiver or somebody else to do it in between. Topicals and wound care dressings, I cannot stress enough, no brand names. There are just, when I moved to Seattle in 2000 from dermatology in New York, and I came here for 24 years now, if you use a brand name, that facility has to use that product. The reality now is there's 20 different types of alginates, 20 different types of hydrocolloids. So no brand names, just use generic alginates, hydrocolloids, no contact layers. Cleansers, I always recommend 3 because home health loves their wound cleansers. So I always say wash with soap and water, saline, or wound cleanser of home health choice. You cannot go wrong, and they will not have to call you if they don't have one of the above. Lastly, who orders and pays for the supplies? If the skilled nursing facility or if they're in a nursing facility or a home health agency is responsible, including for ostomies, they have to pay for all the supplies. If they're outpatient and we're the ones prescribing, we have to be responsible. And I'm just going to tell you, just get comfortable with who your local DME is. They're all over the country. Once you get comfortable with them, all of the stuff I talked about, all the alginates, all the dressings, all of the wraps will get paid for. So just get comfortable and find out who your local DME is and become best friends with them. I still use Byram Healthcare when I'm outside the VA, and I've used them for 24 years now. Lastly, when you refer to us, any wounds that fail to prove to heal in 2 to 4 weeks, again, that can fluctuate based on your comfort level. All stage 3 and 4 pressure ulcers, and really that's important, is the reason they got to a 3 and 4 is because they didn't do what they needed to do to heal the 1 and 2. So 3 and 4s, bring them in. Any wounds, again, that require daily to BID, get them into us. There is just so many different options we have that doesn't require daily. Any leg wounds that you guys want compression therapy, all foot, toe wounds really should go to podiatry. They're diabetic. And lastly, burns, 3rd and 4th degree burns. And I rarely treat burns on the hands, face, feet, or genitalia. So those should be referred to a burn clinic. The references, all up to date. I just updated them last night. And this is your gift for listening to me speak at such a rapid pace with so much information. You can contact me anytime. That's my cell phone, that's my office number, that's my work, and that's my home phone. And people are still calling me from Atlanta about patients. My point is, if you are with the patient, text me a picture. It only takes 3 to 5 minutes of my time. Two things happen. You are learning something quickly. Patient gets specialty care right on the spot. So don't hesitate. I wouldn't give it to you if I didn't want you to use it. I'm retiring in 7.66 years. I'm going to throw that phone away. So take advantage of it for the next 7 years. I wouldn't give it to you if I didn't want you to use it. But here's the truth. I don't have a problem with you contacting me. Let's get your patient specialty care on the spot. And I am so open to asking me any questions. And there's a evaluation, and then should be 10 minutes left, I think, for questions. I can't read the questions, so somebody will have to read them to me.
The question that I see, Quinn, in the chat is from Mary, who's asking if bacitracin is still prescription only, and if it's still pricey.
No, it's so cheap. So I always write a prescription. Here's the beautiful thing. I don't know how, but Medicare and Medicaid always pay for it. If not, the pharmacist is going to tell them to get it over the counter. So it's actually both. But don't hesitate. Just write the script, and it's actually incredibly inexpensive.
And then I see another question from Mary about diabetic shoe stores. She was saying that she remembered in the past there were two, one on Fremont Avenue and the other on Madison.
Oh my God, there are so many, dozens in every single city and every state from here to New York, proven. Times have just changed. They're all over the place. Just again, find your local DME. I'm going to guarantee you there's going to be a prosthetist and orthotist clinic within probably 10 miles of your clinic.
And then Dr. Reed is asking about experience with Pharaoh wraps for patients who are unable to do other forms of compression.
What kind of wraps? Oh, the Pharaoh. Mm-hmm. Yeah, I mean, I love them. They should really be prescribed by a lymphedema therapist because they really are a gradient compression therapy. And the reason it's called gradient is they are custom measuring every inch from the foot all the way up to either the knee or the thigh. So I love Pharaoh wraps because if you need a bandage under it, they need to wear socks. They need to have put big bulky bandages. The best part is they can continue to use that. And on the flip side of that, that is a huge disadvantage of those custom zippered. If they need a bandage, they're kind of out of luck. But again, I do love Pharaoh wraps. They're incredibly easy to put on. And again, as Dr. Reed mentioned, you can actually leave those alone for a week as well.
And then Mary Pat's asking about, it sounds like maybe she's got a situation in mind. I'll read her quote. How would you gently urge someone who is providing wound care in a clinic that does not have a wound care specialist to reach out to a wound care specialist?
Oh, I don't know. Here's the truth. The VA is so home-based medical model, right? My patients don't like to go to podiatrists because they think they're going to cut their feet off. My patients don't like to see wound care, or your patients don't want to see a wound specialist because that wound is scary. Here's what I tell people. Quinn can treat anything, but if you want to keep your feet, you need to see a podiatrist who only treats feet. If you want to see a vascular surgeon because you're varicose veins, they only treat venous issues. So that's what I tell people. We're a home-based medical model. I think maybe UW follows us as well. Let the primary care person be in the center and send them to a specialist who's the best person for them. And then I always like to say, it's a doctor. I don't like Dr. Phil, and I never really watched him, but he did have one quote, which is, how's it working out for you? So the truth is, if you've been seeing the patient in the wound in your clinic for 2-3 weeks and it's not healing, I always literally say, how's it working for you?
I like that, tying that back to that earlier slide with your expected wound healing timelines. Candace, one of our fellows, is asking about recommendations for barrier treatments in the penis area.
Oh, what a beautiful question. So zinc oxide, 20%. It's so beautiful. You can get in a 454-gram jar for a very small copay. You can use it to treat, and if they have tinea, I love mixing my zinc with yeast creams, and I love mixing them also with the triamcinolone steroid creams. The reason why is all of those creams are incredibly thin. If you put miconazole cream, if you put triamcinolone cream on, you put a gauze wrap, it's going to soak up half of that. So I actually add zinc all the time. It makes it thicker. It helps it stay in place. And the best part, It's incredibly soothing, and they can do it long-term without any problems. But zinc oxide 20% is the only prescription you can order that you can get in massive quantities.
I got a big thank you back to you for that answer. That's all the questions I see in the chat. I don't know if others have any last questions with our 4 minutes.
Well, you have my cell. I don't have any kids. They're all in college, so take advantage of it. I wouldn't pick it up if I didn't want you to use it. So text me a picture while you're with the patient. I'll answer it, and let's get them good care quickly.
Ruru's asking if you have any experience with private mobile wound nurse practitioner companies that are available, like Athena.
Yeah, I'm a huge fan of them. If you're at the VA, we are very limited. It's such a new thing. I'm a great advocate and a fan of those mobile. In fact, that's why I'm actually here in Texas now. I'm helping a dermatologist build a mobile wound program, specifically with nurse practitioners going into the homes. I think it's absolutely fantastic. If you can, as long as the insurance pays for them, I believe VA is the only one that truly restricts which agencies they'll accept. But the reality is outside, Medicare and Medicare are paying for all of these different ones. The Athena, they're paying for all of them. So order it. The best part, if they don't cover it, you're going to know it real quickly. So don't ever hesitate to order it just to be safe. You'll be surprised.
And Pam Davies is asking if you could do a quick review again of Medicare criteria for diabetic shoes.
It's very simple. If they have one documented callus, if you can document loss of protective sensation, again, even if they pass and they score a 7, 8 out of 10, I still write limited sensation. If they don't score a 10 out of 10, you can actually put loss of protective sensation. If that is in your documentation, a callus, an ulcer, of course, obviously, and any type of loss of protective sensation in your testing, it should be paid for. 2 pairs of shoes a year, 3 pairs of inserts, custom if appropriate. And always put that on your prescription if appropriate. So let the DME decide.
Great. Well, that looks to me like the end of the questions that are written. I want to express thanks for you continuing to shower your knowledge upon all of us, that you make us all better doctors and all better carers for our complex patients. I'm getting lots and lots of thank yous in the chat about how wonderful your talk is and how wonderful this knowledge is.
I'll send you guys the slides.
Great.
All right.
Have a wonderful time in Texas, Quyen.
All right. Take care.
Bye.